I'd like to invite Dr. Penny Asbell to the podium, and she's going to give us an update on dry eye.
Thank you, Dr. Turner. Pleasure to be here, and I feel like a little bit of a voice in the lone. Typically when we talk about vision research, and particularly funding, which we had a superb presentation on earlier today, we talk about glaucoma, we talk about macular degeneration, we talk about diabetes, and those of us who are involved in the front of the eye, and particularly in dry eye disease, we don't always get a lot of voice in that discussion. And that's because it doesn't cause blindness in the way we normally define that, meaning can you see the chart, okay? And we, of course, would hardly argue with the potential loss and significance of glaucoma, loss of vision, or macular degeneration, loss of vision, or diabetic retinopathy. But I'm here to advocate, if you will, for what happens to the dry eye patient, which is so common in all of us who do clinical practice. And I'm also going to take this opportunity to be up here to argue that we do need to do clinical research. So I very much appreciate the presentations we've had so far today. And as you can see, a lot of it actually comes down to the clinical issue. You know, that's what most of us who are clinicians and went to medical school do actually deal with people. And one of the things that we have noticed in the eye is as the budgets become more difficult to manage, there seems to be, and this is just sort of an outsider looking in, I'm not at all involved in the process, of course, a tendency towards going towards more R1 basic laboratory-based research and less funding for the clinical, which tends to be a bit pricey, I might add, because it's multiple centers and it's expensive research that typically takes several years to complete, such as the ARVO study for one. So I would argue for this group, just as our advocates who go out to the world and talk to people, that when we go to Congress and we go to the Senate or the Congress or both, we often do talk about our clinical trial results, because ultimately all of this research we hope will benefit individuals, actual patients. So do I advance that or you want to do it for me? Is there an advanced mechanism or you want me to advance it? The slides? You'll do it for me, thank you. Okay. So, no, you can just, it's okay. In fact, maybe it'd be better for me to do it myself, or it's easier for you to do it?
If you, no.
I kind of prefer doing it because honestly, I'm not sure I'll remember to do it. Okay, and I speak loudly, so I think you probably can hear me no matter whether we have a speaker or not. So one of the things that people think is dry eye disease is just really isn't that important. Why are we bothering with this? And I think that's kind of what I mainly wanted to talk about today. It's often, like in other diseases, difficult to put your handle on how common this problem is. One way is looking at insurance records and diagnosis, and that's, shows a variable amount, but not that common a problem. And it does suggest perhaps that the disease does progress over time. A key element in our understanding of dry eye disease today has been the DEWS report, or the Dry Eye Workshop, which myself and probably some others here were participated in. We had over 70 people from all over the world participating in putting together all the information about dry eye disease, which has really helped put this problem on the map and isolate this as an individual problem that needs to be addressed by the vision community. So the definition that the DEWS group came up with in 2007, as you read here, is it is multifactorial, which makes it challenging to understand. It involves the ocular surface. It involves symptoms of discomfort, visual disturbance, tear instability, damage to the ocular surface with increased osmolarity of the tear film, and inflammation of the ocular surface. Now, this is a definition of a collection of people, and certainly within that group there are individuals who feel more strongly about some parts of that definition than others. No matter what study you look at, however, what you do notice, whether it's done here in the United States, in Australia, in Japan, you notice with age, we could see an increasing amount of dry eye disease, and just about any study you do. So it's a disease that increases as our population ages, which is a worldwide phenomenon, not just here in the United States. So it's not going away anytime soon. We're going to see it. The other thing that's important is when you look at why people come for an eye appointment, I'm talking about primarily here in the United States, many of them have a complaint that really could be defined as in the realm of dry eye disease. whether it's associated with aging, glaucoma, diabetes, after refractive surgery, contact lenses, systemic medications, and it probably, as many of you know, it's more commonly found with women than men, but men get it too. So though I would argue it's more common in women, I would not want in any way say that this is an unimportant issue for the other sex in our of interest, men as well. And it involves tear film instability, the ocular surface, and mainly I want to concentrate, this is a chronic pain syndrome. And I bet if we went around the room here, and I know I could answer yes to this one, either you have back pain or you know someone in your family who does. And you know when they have back pain, they look kind of normal, right? They're not dying, they're not looking, real disabled per se, but they're not happy. Whether it's yourself or your family member or friend, you know this is a chronic problem that clearly interferes with the individual's life. That's what dry eye disease is. It's the same issue. It's a chronic pain syndrome that affects them at every moment of their waking hours. So though we may not see it in the sense of taking a vision chart and measuring the acuity on the chart, it's there for the individual all the time. There's lots of ways of looking at impact on daily activities. This again is from the Boston group looking at their health providers and their effective dry eye disease on activities. 4 times, if they have dry eye disease, 4 times more affected in reading, professional work, computer work, TV, and driving. All the stuff all of us do in the United States every day that's significantly impacted because they have dry eye disease. Another way of looking at the importance of this problem is quality of life, looking at utility scores. Some of you are probably familiar with that methodology where you sort of do a trade-off. If I could get rid of my dry eyes, how much would I give up, so to speak, to get rid of it? And they compare it among diseases, and interestingly enough, dry eye disease, this is severe dry eye disease, is somewhat equivalent to moderate to severe angina in doing a similar type of study, which clearly suggests for these people, this is a serious problem, whether you want to recognize it or not. They recognize it as something that's important to them. And lastly, one way, particularly today in the United States, the way we measure importance of medical problems is money, okay? When you look at the amount spent on medical treatment, by current, the way we look at money these days from a government point of view, it's $3.8 billion per year in the United States. It sounds like money to me, but in the United States government, that's really not much money. On the other hand, when you start putting in productivity losses, people who don't work, go to work because of their dry eye disease, seek disability and stop working, or they go to work but don't work as hard because they find it difficult to look at the computer and they turn away, etc. Then the estimate in the United States is $55 billion. Still maybe small change compared to trillions, but it's a significant amount of money. And therefore, we have an opportunity to impact budget issues and leave more money for new research that all of us are interested in doing and other activities that the government might support. So I'm going to repeat it again, but one of my real issues is dry eye disease impacts quality of life. And it's not just the patients that we say have dry eye disease as a major problem. It could be dry eye disease associated with cataract, it could be dry eye disease associated with a person who has LASIK surgery, and it could be somebody who has glaucoma. So let's look briefly at one of the other studies that was done by Bill Trattler group on cataract surgeons, patients who had cataract surgery. They took consecutive patients planning to do cataract surgery, they didn't pick them for any particular reason, and evaluated to see whether or not they had evidence of dry eye disease. And when you look at the data, this is one way of looking at it. This is a DEWS scoring system, 0 meaning a normal eye, 1, 2, 3, or 4, the grading or severity of dry eye disease, with 4 being more severe. You can see over 3/4 of these routine cataract patients had significant findings that were consistent with dry eye disease. Staining of the cornea, decreased Schirmer's, and symptoms. So it's a common problem, whether we want to acknowledge it or not, even in our typical cataract patient, which of course is still the most common ocular surgery that we do in the United States, and one of the highest in volume of any surgery done in the United States. What does it impact cataract surgery? Well, we need good measurements to get the IOL measurement correct, and if we don't have a good surface, we don't get good measurements. It affects visual outcome. where the quality of vision isn't what we expected, and ultimately a reduced satisfaction from the patient, and I might add from the surgeon, after putting in all that effort and still not getting the results they want. Now, what about glaucoma patients? Glaucoma people, we have any glaucoma people here today? Experts? Okay. You know, you hone in on that IOP. Okay, actually, I treat some glaucoma too. We all do that. We want that pressure. We have our guidelines decreased by 30% or whatever it is, depending on the diagnosis and the findings. We hone in, what's the IOP today? But part of what we have to look at is that a lot of the glaucoma drops impact the ocular surface, and in a sense, we induce a dry eye type problem. We either have dry eyes or we make it worse, or we induce it with the drops themselves. There's lots of data on toxicity of glaucoma drops to the ocular surface, causing inflammation of the ocular surface and instability of the tear film. And what happens is, in a series of studies, there's a lot of data here, but over 50% of patients who are on glaucoma drops show evidence of ocular surface disease consistent with what we call dry eye disease or ocular surface disease. And it's more common the greater number of drops they're taking, and is probably related specifically to BAK, or the preservative, as you can see in this list of some of our common glaucoma medications, which is commonly used in the United States for all drops, glaucoma drops and other drops as well. It's easy to get through the FDA because it's a preservative that they're used to using. This is a study we did to show that even if you get down to the tiniest concentration of BAK, it still affects the ocular surface. This is done in tissue culture, looking at conjunctival and corneal cells, and even if you have a little bit of BAK, it is very toxic to surface cells, and you really basically can't get away from this. Well, does this matter? Yeah, it does matter to your patients, because if your ocular surface is not good, you don't see well. One of the things that happens with a dry eye patient is in the office, we always take the vision, 100% of our patients, right? That's a common, we do that in every exam. Well, the dry eye patient will blink a lot, then they'll read the bottom line on the chart, they'll see 20, 30, 20, 25, 20, 20. You'll say, you don't have a vision problem, your vision's great. But that's not what they're doing every day while we're sitting around this room. We're not sitting here blinking like this, okay? So if you look at functional vision, they actually could be 20, 50, 20, 70, actually not even have good enough vision to legally drive a car. But that's not what you get in the office when they're trying hard and blink. Well, what happens with a glaucoma patient? If they have pain from ocular surface disease, dry eye disease, if they have reduced quality of vision, you're going to impact their compliance. If you impact their compliance, then they can lose vision permanently from the glaucoma itself. So it's important to think about even in glaucoma patients. I just have a few more slides because I know everybody at ARVO is like crazy. But including myself, right, these ridiculous schedules we try to keep. I'm lucky. I have a lot of fun, and I like what I do. Okay, I am a clinician, I already mentioned that. I do lots of clinical research, which I very much enjoy doing, and I work with several great basic scientists in the laboratory. So we do patient care, which makes me think of things I want to study and understand better. I do clinical trials, hopefully coming up with new treatments, and we work in the laboratory to see if we can get a more basic understanding of the mechanisms of action, which will give us the right targets for new ideas for treating patients. One thing that we've been doing a lot on is we've set up a biomarker laboratory. We feel with minimally invasive techniques, we can get a better handle on the mechanism of dry eye disease that we don't have. This is impression cytology. You use a little piece of filter paper. After you put a numbing drop on the eye, if you leave it there barely a second, not even a second, it takes off a few of the surface cells, which can be analyzed in a flow cytometry methodology, and then you can analyze them with markers, as we've done in this group of dry eye patients shown here, and ensure that if this particular marker, HLA-DR, a sign of inflammation on the ocular surface, increases with increasing severity of the dry eye disease. And it's this type of work that eventually, this is looking at tear cytokines, which go up in dry eye disease. It's this type of biomarker work, which I personally think are going to give us the breakthroughs to understand the mechanisms that cause dry eye disease, that cause the changes in the ocular surface. Now, I do mice also. and I can make them all do the same thing and look the same, et cetera. Not like my patients who come in all sizes for all the problems. But I think ultimately, we're going to have to look at people to really understand some of these diseases, because our animal work may not totally imitate some of the issues that we see in people. Other area that I think is very interesting and potentially has a lot of ramifications in eye disease is looking at inflammation. We didn't talk too much in AMD about inflammation, but that is one of the elements they're looking at in macular degeneration. In ASHD and heart disease, they're looking at inflammation, and they're certainly looking at inflammation in dry eye disease. Usually, you get this cascade with inflammation that ends up with the prostaglandins and the leukotrienes and the other things at the bottom of this cascade. We've specifically focused on phospholipase A2, simply stated SPLA2, which is an enzyme which, if you can block, is at the top of the cascade. And if you can block it at the top of the cascade, you don't get the inflammatory markers. And what we show here is, these are mice, dry eye induced mice, and you can see there's lots of corneal staining, the fluorescein staining on your left. And if you put an inhibitor in, as you can see, as we did on the same treatment protocol on your right, we can improve the ocular surface. And there could be a role for controlling inflammation associated with dry eye disease with using SPLA2 inhibitors, which is one of the areas we're looking at. Just about done. Dry eye disease is really part of everything we do. I mean, I'm not knocking glaucoma or macular degeneration as important areas of research and understanding and taking care of, both in the laboratory and in clinical practice. But you got to remember, dry eye disease impacts almost every one of our patients, particularly as we age. It affects the quality of life, it affects productivity, it affects surgical outcomes. We actually have data now showing that you can, in glaucoma patients, some of the BAK may actually get into the trabecular meshwork, cause inflammation, and impact your ability to treat that patient effectively. It certainly can affect glaucoma surgery and the healing afterwards. So it may not be sight-threatening dry eye disease, but it's certainly important, just as back pain is, to anybody who is going to do cataract surgery, LASIK, ocular surface disease, glaucoma, and that's true here in the United States and elsewhere. So we're going to take on the formatting here, but it's common. The population is graying here and elsewhere in the world. It does happen to affect women more than men, but it's a universal problem. And I'd like to sort of remind you, it's a chronic pain syndrome. From the individual's point of view, they're losing vision, whether or not we can measure that accurately in the office. So it's not to be forgotten about. And hopefully from this brief presentation, you'll at least be thinking about this, whether you're involved in patient care, basic research, funding, or all the other things that many of us here at ARVO are interested in.